Ocular Pathology Review, Part 2, Conjunctiva, Cornea, and Lens. From the Department of Pathology at the Wills Eye Hospital and the Sidney Kimmel Medical College at Thomas Jefferson University. The term conjunctiva is derived from the Latin meaning to bind together. It binds together the eyelid and the eyeball. The conjunctiva is lined by a non-keratinized stratified squamous epithelium that contains goblet cells. The goblet cells are most numerous in the nasal conjunctiva near the plica semilunaris or semilunar fold seen above. The goblet cells are PAS positive. The great majority of conjunctival disease is inflammatory and really doesn't make it to the laboratory. Here's an example of acute purulent conjunctivitis due to H. flu. The histopathology was an incidental section showing polymorph nuclear leukocytes comprising the exudate and infiltrating the epithelium. Follicular conjunctivitis is one of the two types of chronic conjunctivitis. This is characterized by the formation of follicles of lymphoid tissue, shown here. They may or may not have a germinal center, as this one does. A lot of times the lymphoid follicles don't have a germinal center. There are numerous causes of follicular conjunctivitis. This is an example of folliculosis in a patient with adenovirus infection. Here's chronic follicular conjunctivitis secondary to an eyelid molluscum contagiosum. The second variety of chronic conjunctivitis is papillary hypertrophy. Conjunctival papillae frequently occur on the upper eyelid. Giant cobblestone papillae are seen in vernal keratoconjunctivitis, or so-called vernal catarrh. This is a allergic condition. It also has thick mucin with chewing gum consistency, rich in eosinophils. The giant papillae can abrade the cornea, giving rise to a superior shield ulcer. That happened in this case. The oculoplastic surgeon shaved off the papillae to prevent the ulceration, and here is a histologic section showing the characteristic histopathology of vernal conjunctivitis. We see a moderate amount of inflammation with eosinophils in the papilla and a characteristic central vessel. Follicles composed of sheets of lymphocytes. Again, the vessels and follicles tend to be present in the periphery of the lesion. In contrast, the vessels and papillae are central and the periphery is avascular. Paranoid's ocular glandular syndrome is granulomatous conjunctivitis with regional lymphadenopathy. There's a rather broad differential diagnosis. A classic example, of course, is cat scratch fever caused by Bartonella-Henselae infection. Here's a case of cat scratch conjunctivitis that was seen on the oncology service a few years ago. Patient has a unilateral involvement, had a preauricular node and multiple scratches on the arm from a pet cat. Histopathologically, cat scratch conjunctivitis is a granulomatous conjunctivitis with geographic areas of necrosis. The organism does not stain with the Gram stain. You have to do special silver stains like the Worth and Starry stain to demonstrate the clumps of microorganisms. Follicles, of course, occur in trachoma. We do not see trachoma in our laboratory. This is from the WHO World website a few years ago. You can see the classic Arlt's line of conjunctival scarring. Of course, blindness results from trichiasis and loss of tear production and mucin in the late stages of the condition. This is an old conjunctival scraping from trachoma from Yanov's collection. It shows the presence of the intracytoplasmic inclusions of Halberstadt and Projacek in the conjunctival epithelial cells and the mixed infiltrative lymphocytes and plasma cells. Two types of conjunctival membranes, which tend to be talked about. I'm not sure how important this is anymore, but we'll talk about it some more. There are true membranes, where the inflammatory exudate is firmly adherent to the epithelium. These are caused by bad things like diphtheria and GC and Stevens-Johnson syndromes, and classically, bleeding occurs when true membranes are peeled. Pseudomembranes are less adherent and they peel without bleeding. There's lots of different causes of them. One type of pseudomembranous conjunctivitis is ligneous conjunctivitis. It's called ligneous because there is a very firm, woody-like consistency of the masses on the conjunctiva. These masses are composed of a mixture of granulation tissue and fibrin. It's now known that this is actually genetically based, and it's caused by mutations in the gene for plasminogen. So ligneous conjunctivitis, plasminogen deficiency. This is a rare infectious disease, actually caused by an organism that's probably a fungus called rhinosporidiosis. The lesions are said to look like strawberries with white seeds. The white seeds are actually sporangia. Here's the classic histopathology of rhinosporidiosis, the round trophozoites. This is most common in India. It was said to be seen in so-called Indian sand divers. This is an example of synthetic fiber granuloma, an 8-year-old boy with his mass in the inferior cul-de-sac. This mass actually contained a fuzzball composed of synthetic fibers. Histopathology shows foreign body giant cells surrounding the synthetic fabric fibers, which of course are birefringent. This has also been termed teddy bear granuloma after this case in our original series. This was a patient of Dr. Barbara Streeton's in Syracuse, New York. The fuzzball in this patient had fibers that were identical to those in the patient's teddy bear, hence the term teddy bear granuloma. This is an example of the Splendori-Hopley phenomenon of antigen-antibody complexes in the allergic conjunctival nodule described by Norman Ashton many years ago. Conjunctival smear of allergic conjunctivitis showing lots of eosinophils. In contrast, we see lymphocytes in chronic conjunctivitis. There's always some degree of actinic elastosis in the sun-exposed portion of the conjunctiva. When it forms an actual nodule, this is termed a pinguecula. Again, it's not a pingueculum, it's a pinguecula. This is comprised of actinic elastosis of collagen in the substantia propria, basophilic granularity, and vermiform degeneration of collagen. The material does stain positively with the Verhoef-Van Giesen elastic stain, but is not subject to elastase digestion. Another degenerative condition is conjunctival amyloidosis. This can be quite variable in appearance. Can sometimes resemble lymphoma or sarcoidosis. Conjunctival amyloidosis typically is composed of light chains, but it usually is unassociated with systemic amyloidosis. Here's histopathology of a case showing the amorphous eosinophilic deposits in the substantia propria. These, of course, do stain positively with the Congo red stain and exhibit apple-green birefringence and dichroism with polarization microscopy. There are several types of chorostomas of the conjunctiva. We have the solid epibulbar dermoids, dermolipomas, complex chorostomas, and the epibulbar osseous chorostoma. Solid epibulbar dermoids, shown in the clinical photo here, are frequently associated with Goldenhar syndrome. These are essentially little nodules or foci of skin on the surface of the conjunctiva. They may have pilosebaceous units on their apex, and the stroma typically is composed of coarse bundles of collagen. So Goldenhar syndrome, solid epibulbar dermoids. A dermoid that has lipid in it is called a lipodermoid or a dermolipoma. The question whether these one of these cases here may represent herniation of orbital fat rather than a lipodermoid. Complex chorostomas have other elements, including hyaline cartilage and lacrimal gland. This is a case in a patient with organoid nevus or the nevus sebaceous of Viadasen syndrome. This is the clinical photo of an epibulbar osseous choristoma. I've seen several of these in my career. These are actually little nodules of mature bone beneath the conjunctival epithelium on the surface of the eye, typically in the supratemporal quadrant. Here's the histology of that case showing the bone beneath the conjunctival epithelium. So it's an epibulbar osseous choristoma. Conjunctival tumors come in three flavors: squamous, lymphoid, and melanocytic. The squamous tumors include papillomas, intraepithelial neoplasia, which people tend to call OSSN or ocular surface squamous neoplasia. This includes the intraepithelial neoplasia and invasive squamous cell carcinoma. Melanocytic tumors, we see a fair number of nevi, and the precursor lesion for melanoma, primary acquired melanosis. And of course, malignant melanomas do occur in the conjunctiva. Lymphoid tumors, we have reactive hyperplasias. The term atypical lymphoid hyperplasia tended to be used in the past before immunohistochemistry was widely available to determine whether you did have a lymphoma or not. And then we do have obvious malignant lymphomas, which we'll talk about in greater detail. Here's a conjunctival papilloma in a young patient. Again, it's a papilloma. We have multiple fronds of epithelium. The epithelium here is transparent, so we can see the vessels in the vascular cores, so classic hairpin loops. Viral papillomas do occur in children. Here's the histopathology of a pedunculated conjunctival papilloma. Again, hairpin vessels representing vessels in the fronds. This is a rather rare hereditary condition called hereditary benign intraepithelial dyskeratosis. It's caused by duplication in the chromosome 4q35. It gives rise to bilateral squamous lesions. As we see here, there's actually two squamous lesions with keratinization and leukoplakia in the same eye of this patient. So hereditary benign intraepithelial dyskeratosis. The parakeratin in these lesions is very characteristic. It's composed of round dyskeratotic cells. This condition initially was described in a triracial isolate called the Haliwa Saponi Indians, who live in Halifax and Warren counties of North Carolina. Leukoplakia, white plaque, generally means that there is keratinization, and if you see keratin, it means you're dealing with a squamous cell lesion. Squamous cell lesions of the conjunctiva tend to occur in the sun-exposed interpalpebral portion of the conjunctiva, near the limbus where the stem cells reside. Occasionally, they do occur on the back of the lid, however, and you'll never diagnose one unless you flip the eyelids. Conjunctival intraepithelial neoplasia is a spectrum of disease, neoplasms of the squamous epithelium. We said they occurred typically in the sun-exposed conjunctiva, near the limbus. Some cases are leukoplakic, other cases are rather gelatinous in appearance, and occasionally you'll see papillary lesions as well. The epithelium in these is replaced totally or in part by a new clone of atypical squamous cells. These can be epidermoid with lots of cytoplasm or more spindly, which you tend to see in the gelatinous lesions. Again, if less than 50% of the epithelium is replaced, it's termed mild dysplasia. Severe dysplasia is greater than 50%. If the entire thickness of the epithelium is replaced by atypical cells, it's called carcinoma in situ. This is still considered to be pre-malignant because the basement membrane is intact. If the basement membrane is violated and perforated, we are dealing with invasive squamous cell carcinoma. As I said before, the term OSSN, ocular surface squamous neoplasia, is sort of a blanket term for this spectrum. Here's a cartoon showing conjunctival intraepithelial neoplasia. We see a new clone of dysplastic cells arising from the basal portion of the epithelium. There's typically an abrupt transition between the dysplastic cells and the normal adjacent epithelium. The basement membrane is intact. And here's an example in the limbal conjunctiva. Here's the normal limbal epithelium. The neoplastic epithelium appears basophilic because the cell density is much higher. Cells have less amounts of cytoplasm. Again, typical abrupt transition, and the basement membrane is intact, so this is carcinoma in situ. In this cartoon, we see carcinoma in situ with the intact basement membrane, and then this can break through to form invasive squamous cell carcinoma. Here's histopathology of invasive squamous cell carcinoma. Our abrupt transition is seen superiorly. We see lobules of invasive tumor in the substantia propria, comprising the vertical growth phase. Now, run-of-the-mill squamous cell carcinoma of the conjunctiva tends not to invade the eye or the orbit. Now, there is an exception. What used to be called mucoepidermoid carcinoma of the conjunctiva, which now it's called adenosquamous carcinoma in the latest WHO book, has a propensity to invade, and so does high-grade spindle cell carcinomas. This is an example of intraocular invasion by mucoepidermoid carcinoma. There's actually keratin in the anterior chamber in this case of malignant epithelial downgrowth. Again, as I said, this is now referred to as adenosquamous carcinoma. These squamous cell carcinomas do have mucin production and goblet cells. One of the classic clinical features that helps you diagnose squamous lesions are the presence of vessels. So you saw the vessels in the conjunctival papilloma. Here are somewhat similar vascular patterns, more irregular in a case of papillary CIN. Histopathology of that lesion shows that the frons surrounding the vessels, the epithelium is totally replaced by atypical squamous cells, so this is a carcinoma in situ surrounding vessel cores. In heavily pigmented individuals, squamous cell lesions can appear pigmented. So this is an example of a pigmented squamous cell carcinoma in an African American patient. Here is the histopathology, again, a classic abrupt transition, a sessile papillomatous proliferation, totally replaced by atypical squamous cells. And under higher magnification, we see this reactive melanocytosis. Again, these are not malignant melanocytes. It doesn't take that many melanocytes to make the lesion look pigmented. Lymphoid lesions of the conjunctiva are fairly common. They frequently have this salmon-patched appearance. When dealing with a conjunctival lymphoid lesion, you want to make sure that it is confined to the conjunctiva and does not represent the tip of the iceberg of an orbital lesion. Again, they have this salmon patch or loxoid appearance to them, this typical salmon color. Lymphoid lesions include follicular lymphoid hyperplasias, atypical lymphoid hyperplasias, and malignant lymphomas. Conjunctival lymphoid tumors typically arise from the resident population of lymphocytes in the conjunctiva. They're rarely the initial manifestation of a systemic lymphoma. In an old paper by Jacobiak and co-workers, 20% of the patients with conjunctival lymphoma had a prior systemic lymphoma, had a concurrent systemic lymphoma, or developed a systemic lymphoma. The great majority of conjunctival lymphoid tumors are low-grade extracellular, extranodular marginal zone lymphomas of mucosa-associated lymphoid tissue, or so-called MALT lymphomas. Pathology typically shows a diffuse monomorphic monoclonal infiltrate of well-differentiated B cells. Here's an example. This case has a pebbly appearance to this, and this case does have germinal centers and And this shows the immunohistochemistry, the B cells comprising the lymphoid follicles with the intervening T cells shown by positivity for CD3. So this is a benign reactive follicular hyperplasia. Here's another salmon patch. This one is sort of a diffuse infiltrate, composed of no germinal centers. It's a monomorphic infiltrate. The cells may involve the conjunctival epithelium. Lymphomas are monoclonal. The cells have a predominance of one type of light chain, either kappa or lambda. And the best way to determine this is to do flow cytometry. The problem with conjunctival lymphomas, there's frequently insufficient tissue to do flow cytometry. They said that you need about the size of a pea fresh tissue to do this. And so a lot of times we have to do other sorts of immunohistochemistry to confirm the diagnosis. Again, 60 to 70% of ocular adnexal lymphomas are these extranodal marginal zone lymphomas or MALT lymphomas. We do see follicular lymphomas, we see mantle cell lymphomas, we see rare cases of chronic lymphocytic leukemia or small lymphocytic lymphoma, and rare cases of large cell lymphoma. We said before, 60 to 70% are extranodal marginal zone lymphomas of mucosa-associated lymphoid tissues. The immunohistochemical stains we typically use to classify lymphomas include the CD3 stain for T cells. The CD5 stain is also for T cells, but it does stain mantle cell lymphomas and small lymphocytic lymphoma as well. CD10 is the stain for follicular lymphoma. CD20 stains all of them, pretty much all of them, because they're all B-cell lymphomas. And CD20 is the B-cell marker. CD23 stains follicular dendritic cells. BCL2 is an anti-apoptotic protein that is present in follicular lymphoma, used in that diagnosis, and BCL1 or cyclin D1 is expressed by mantle cell lymphoma. So those are some of the immunostains that we use. Here's how we classify. Again, MALT lymphomas are positive for CD20. Again, most of them are B-cell lymphomas, and they're all CD20 positive. But the MALTs are negative for 5, they're negative for 10, and they're negative for CD23. Follicular lymphomas are CD20 positive and also stain the follicular cell marker, CD10. And the follicles also express BCL2. Reactive follicles are negative for BCL2. Mantle cell lymphoma is positive for CD20, but the B cells also co-express T cell marker CD5. And they're CD23 negative and express cyclin D1 or BCL1. CLL, SLL is also positive for 20 and 5. It's also positive for 23 and negative for cyclin D1. So this negativity and positivity for cyclin D1 and CD23 help us differentiate mantle zone from CLL. Here's a photomicrograph of MALT lymphoma. Here's the panel of immunohistochemistry. Again, pretty much all the cells are CD20 positive B cells. Now, there's always some T cells floating around, so we do see this smattering of CD3 positive lymphocytes, and CD5 also looks quite similar. CD10 is negative, excluding a follicular lymphoma. Here's another photomic, same magnification. These nuclei are a bit larger, a little bit more irregular. Some have minor nucleoli, and there's a mitotic figure. This is the case of mantle cell lymphoma, and this is the immunohistochemistry. Again, the cells are positive for B-cell marker CD20. Again, there's a smattering of CD3 T cells, but note that the 5 looks like 20, not like the 3. So the B cells are co-expressing the T cell marker CD5, and they are also expressing cyclin D1 or BCL1. So this is consistent with mantle zone. Why is that important? Well, this is one of the more malignant types of lymphomas, tends to be widely disseminated at presentation and occurs in older males. In the stomach, malt lymphomas are associated with Helicobacter pylori infection. In the conjunctiva, the role of this infection is somewhat unclear and controversial. Primary melanocytic lesions of the conjunctiva include nevi, congenital ocular melanocytosis, freckles or aphelidades, complexion-associated melanosis, intraepithelial melanocytic lesions with or without atypia, and conjunctival melanoma. Most conjunctival nevi are located on the bulbar conjunctiva near the limbus, or in the plica semilunaris. Nevi of the tarsal conjunctiva are quite rare. Many conjunctival nevi are excised from teenagers because they often enlarge and become more pigmented during puberty, as seen in these photos. Histopathologically, conjunctival nevi are classified as junctional, compound, and subepithelial. In junctional nevi, which are rare, the nevus cells are confined to the epithelial-subepithelial junction, and the underlying subepithelial stroma is uninvolved. Compound nevi are most common. About 2/3 of conjunctival nevi are compound. Compound nevi have both a junctional and subepithelial component. In subepithelial nevi, the nevus cells are confined to the subepithelial stroma, and junctional activity is absent. Subepithelial nevi have no malignant potential, which resides in the junctional component. Subepithelial nevi are common in older patients because the junctional component diminishes with age and is lost. Nevi in adults typically have little or no residual junctional activity. Therefore, a purely junctional nevus or significant junctional activity in an adult is worrisome and should be considered to be primary acquired melanosis, an extremely important precursor for conjunctival melanoma, until proven otherwise. Intralesional cysts are a common finding in conjunctival nevi. More than 60% of conjunctival nevi contain cystic or solid rests of surface epithelium. These cysts are a helpful clinical marker for nevi, but they don't totally exclude the presence of melanoma because melanomas can arise from nevi. The cysts in nevi typically enlarge with age. Inflamed nevi of puberty may have disturbing, atypical histopathologic features. However, malignant melanoma is rare in childhood, and the rate of malignant transformation of nevi to melanoma is less than 1%. I typically diagnose such cases as inflamed nevi with severe atypia, and I recommend total excision and careful follow-up. Blue nevi occasionally occur in the conjunctiva. Simple blue nevi are composed of pigmented spindle cells with a wavy dendritiform configuration that are located in the substantia propria or dermis. Nevi composed of a mixture of typical nevocellular nevus cells and spindle cells resembling those found in blue nevi are called combined nevi. The pigmented blemishes that occur in congenital ocular and oculodermal melanocytosis of the nevus havota are composed of spindled and dendritiform melanocytes located in the epibulbar tissues. The deeply situated pigment does not move with the conjunctiva and appears blue or slate gray due to the Tyndall effect, as light passes through the overlying substantia propria and epithelium. In the left part of this photo, the epibulbar pigment appears brown where it is exposed by a rip in the conjunctiva. Seen through intact conjunctiva at right, the pigment has a characteristic slate gray appearance. Nevus havota does not predispose to conjunctival melanoma. An associated nevus of the uveal tract predisposes Caucasian patients to uveal malignant melanoma. Their estimated risk of developing a uveal melanoma is 1 in 400. In addition, they have a twofold greater risk of developing metastatic disease. A spectrum of pigmented lesions involves the conjunctival epithelium. These include constitutional or complexion-associated melanosis, freckles, reactive melanocytic proliferation, and neoplastic melanocytic proliferation with or without atypia. The latter can progress to invasive melanoma. Constitutional or complexion-associated melanosis, previously called racial melanosis, is a benign condition that occurs in heavily pigmented individuals and typically affects both eyes. Histopathologically, the melanin pigment is present within the squamous epithelial cells of the conjunctiva, and significant melanocytic hyperplasia is not present. The pigment may involve the entire thickness of the epithelium, where it often forms umbrella-like apical caps in the most superficial layers that presumably shade and protect the nuclei. Care must be taken when assessing pigmented lesions in heavily pigmented individuals, as they are not immune to malignant melanocytic neoplasms. Atypical melanocytic hyperplasia has been misinterpreted clinically as complexion-associated melanosis in some cases. This African-American woman developed a large malignant melanoma of the conjunctiva that arose from PAM with severe atypia. The thoroughly ingrained term primary acquired melanosis, or PAM, has been applied to an important spectrum of conjunctival epithelial pigmented lesions that involves varying degrees of intraepithelial melanocytic proliferation. The pigmentation of squamous epithelial cells found in complexion-associated melanosis comprises the benign end of the spectrum and has been termed hypermelanosis by some. Primary acquired melanosis is called CMIL, or conjunctival melanocytic intraepithelial lesion, in the WHO classification of eye tumors. Other terminology was proposed previously. D'Amato and Coupland proposed the term CMIN, or conjunctival intraepithelial melanocytic neoplasia, and suggested that the term hypermelanosis be used for constitutional melanosis. The late Frederick Jacobiak suggested the term IMP, or intraepithelial melanocytic proliferation, in an editorial in the AJO. Most clinicians and many pathologists continue to use the term primary acquired melanosis, and some believe that changing the terminology makes a confusing topic even more confusing. Primary acquired melanosis is characterized by the proliferation of atypical melanocytes within the conjunctival epithelium. The condition is unilateral and typically affects middle-aged or elderly Caucasian patients. The pigmentation has an insidious onset and often waxes and wanes. The pigmentation is brown in color and it moves with the conjunctiva because it is located within the epithelium. Primary acquired melanosis is a major precursor for conjunctival malignant melanoma. Varying degrees of atypical melanocytic hyperplasia occur in this disease spectrum. These photomicrographs show PAM with mild atypia, PAM with moderate atypia, and PAM with severe atypia. Histopathologic features in cases of PAM with atypia that predict progression to melanoma include the presence of atypical melanocytes that are not confined to the basal part of the epithelium, and the presence of epithelioid melanocytes. Pagetoid spread and nests of melanocytes are other factors associated with poor prognosis. Prognosis is better if the melanocytes are confined to the basal epithelium in a lentiginous pattern. Many call total replacement of the epithelium melanoma in situ. Here's another example of PAM with severe atypia or melanoma in situ, where the entire thickness of the epithelium has been replaced. Another example, PAM with severe atypia, melanoma in situ. Atypical melanocytes are not confined to the basal epithelium, and there's epithelioid melanocytes. Not all PAM is pigmented. You can have PAM with cinepigmento, and this is an example of that, where you have lots of non-pigmented atypical melanocytes replacing most of the epithelium in this case. PAM with atypia is an important precursor of invasive conjunctival melanoma. About 75% of conjunctival melanomas arise from PAM with atypia, when the atypical melanocytes breach the epithelial basement membrane and a vertical growth phase of invasive melanoma ensues. Conjunctival melanoma is relatively rare. It is 1/10 as common as uveal melanoma, and its mortality rate of 26%, while significant, is half that of its uveal counterpart. Conjunctival melanoma is more similar to cutaneous melanoma than uveal melanoma. It metastasizes to lymph nodes, not to the liver like uveal melanoma. And some conjunctival melanomas have BRAF mutations, which are absent in uveal tumors and can be treated with targeted therapy. Extralimbal location and positive surgical margins are factors associated with poor prognosis. When assessing a pigmented conjunctival lesion, the pathologist must answer several questions. Is the pigment contained within squamous epithelial cells or within melanocytes? Is there an increased number of melanocytes? Are the melanocytes atypical? Where are the atypical melanocytes located? Are they confined to the basal epithelium, or do they involve more superficial layers? Have they extended into the substantia propria as invasive melanoma? The histopathologic assessment of conjunctival lesions is often challenging. We have found that immunohistochemistry is a helpful adjunct in the assessment of these lesions. Immunohistochemical stains for melanocytic markers like melan-A and SOX10 confirm that lesions are melanocytic. They also can disclose the presence, extent, and location of melanocytic hyperplasia that may be inconspicuous in routine H&E stain sections of amelanotic lesions. These photos show extensive replacement of the epithelium by atypical melanocytes in a case of PAM with severe atypia. In contrast, these photos of complexion-associated melanosis show that the pigment is present within the epithelial cells and no melanocytic hyperplasia is present. Immunohistochemistry also provides clues that help to differentiate between nevi and melanomas. These photos show a melanoma arising from a nevus. Both the nevus and the melanoma stain intensely with melanocytic marker melan-A. At bottom left, we see that the melanoma stains positively with melanoma marker HMB45, but the nevus does not stain. The Ki67 proliferation marker shows significant cellular cycling within the melanoma, which is absent in the nevus. The lymphocytoid subepithelial nevus in these photos stains intensely with melan-A, but is negative for HMB45 and Ki67. It was also negative for PRAME, a newly available stain that appears to be a promising marker for malignant melanocytic lesions. Other pigmented lesions of the conjunctiva include pigmented squamous cell tumors, systemic diseases like Addison's disease and ochronosis, drug deposits such as epinephrine, tetracycline, and argyrol, tattoos, cosmetics like mascara and kohl, pigmented mycotomas, and metastatic cutaneous melanoma. As we noted before, squamous cell lesions in pigmented individuals may be significantly pigmented due to a reactive proliferation of melanocytes. Cogencinal plaque is calcification of the sclera that occurs at the anterior margin of the rectus tendons in elderly patients. Brown deposits of ochronosis typically are found anterior to the insertion of rectus muscles in patients with alkaptonuria. Chronic instillation of silver-containing medications like argyrol can cause grayish pigmentation of the conjunctiva. The photomicrograph shows silver particles attached to reticulum fibers in the substantia propria. Argyrol was a silver protein compound that was used to treat infections prior to the advent of antibiotics. The inventor, Dr. Albert Barnes from Philadelphia, made a lot of money selling argyrol and amassed a major collection of Impressionist art that forms the basis for the Barnes Museum in Philadelphia. Accidental or intentional tattooing can cause conjunctival pigmentation. This case was a miner who was injured in a coal mine explosion. This is an example of cosmetic tattooing performed by a tattoo artist. This patient developed a pigmented mycetoma after injuring her eye in a rose garden. The photomicrograph shows the mass of pigmented fungal hyphae. This photo shows cutaneous malignant melanoma metastatic to the conjunctiva. The pigmented melanoma cells are growing within the lumen of lymphatic channels in the substantia propria. The caruncle is a little island of skin surrounded by conjunctiva. It's located nasally near the semilunar fold. There are a variety of tumors that can occur in the caruncle. There are rare cases of sebaceous carcinoma arising from the sebaceous glands there. There are frequently nevi of the caruncle. And an interesting tumor of the caruncle is the oncocytoma. An oncocytoma is derived from the accessory lacrimal glands of Popov. The oncocytes have abundant quantities of eosinophilic cytoplasm. The granular cytoplasm is rich in mitochondria, which typically have abnormalities in mitochondrial DNA. So oncocytomas also can occur in the conjunctiva, in the lacrimal sac, and oncocytic change can occur in the lacrimal gland as well. The cornea. Congenital corneal lesions include microcornea, defined as less than 10 millimeters in diameter, megalocornea, cornea greater than 13 millimeters in a patient with a normal interocular pressure, sclerocornea, sort of a manifestation shared by a variety of hereditary conditions, not a specific entity, Axenfeld-Rieger syndrome, Peters anomaly, and the posterior ulcer von Hippel related to PAX6 mutations and solid epibulbar dermoids. Axenfeld-Rieger syndrome is a disease spectrum. About 50% of patients have glaucoma. We see characteristic features such as the posterior embryotoxin of Axenfeld and enlarged anteriorly displaced Schwabe's line. Axenfeld's anomaly, where the angle is bridged by strands of iris that assert into the embryotoxin. Rieger's anomaly, where you have other abnormalities in the iris, including stromal hypoplasia, correctopia, and polychoria. Then we have Rieger syndrome. We have all of the above, plus systemic abnormalities involving the midface, the teeth, and other interesting things like redundant periumbilical skin with hypospadias and growth retardation. Here's an example of a posterior embryotoxin above, enlargement and anterior displacement of Schwabe's ring. Axenfeld's anomaly at below, we see broad iridocorneal adhesions to the posterior embryotoxin. Again, these may bridge the angle and may not block the trabecular meshwork, so you don't always have glaucoma. Here's an example of Axenfeld-Rieger syndrome, where we see the characteristic features in the iris and the posterior embryotoxin. There is maxillary hypoplasia in the face, redundant periumbilical skin, and dental anomalies, including the anodontia, oligodontia, and peg-like incisors. Congenital opacities of the cornea, posterior keratoconus. I've seen one example at a pathology club. There's a posterior umbilication of the central cornea with Descemet's membrane and endothelial present. In posterior ulcer von Hippel, Descemet's membrane and the endothelium are absent centrally. They are also absent centrally in Peters anomaly. Peters anomaly also has iridocorneal and keratolenticular adhesions and may have an anterior polar cataract. Here's an example of Peters anomaly. Central opacity, we can see the strands of iris tissue adhering to the margin of the opacity. Histopathologically, there is absence of Descemet's membrane and endothelium in the area of the opacity. You may see a thickened abnormal posterior stromal lamellae as well. And of course, we see a very impressive keratolenticular adhesion, the lens filling the posterior ulcer in this case. Another example of a keratolenticular adhesion, in this instance in a patient with fetal alcohol syndrome. Some of the genes that can be associated with Peters anomaly are shown here. It's also been reported with Accutane drug and fetal alcohol syndrome. Keratitis can be acute or chronic. Acute keratitis typically is caused by infection by bacteria or fungi. Histopathologically, we see the accumulation of polymorphonuclear leukocytes initially in the interlamellar clefts. As the skin spread, causing a necrotizing keratitis with dissolution and ulceration and loss of substance. This section shows an ulcer in a patient with fungal keratitis. The fungi disclosed by the GMS stain may reside quite deep in the stroma, and a superficial corneal scraping may not be diagnostic. The fungal hyphae can grow right through Descemet's membrane into the anterior chamber, giving rise to secondary fungal endophthalmitis. Here's an example of a desmetocele where the entire stroma of the cornea has been lost, disclosing Descemet's membrane. This is a non-infectious sterile perforation, a so-called rheumatoid melt. Note the minimal inflammation in the wall of the ulcer, the relatively sharp margin. Infectious pseudocrystalline keratopathy can occur in patients who have been on chronic steroid therapy for a potential graft rejection, has occurred in this patient. Here is this crystalline-like deposit shown under higher magnification in the pathology specimen. The snowflake-like appearance actually reflects the presence of large intrastromal colonies of relatively avirulent bacteria, typically strep viridans, which are sequestered by the formation of a glycocalyx. Note the paucity of inflammatory cells surrounding the bacterial colonies. Here's a gram stain confirming that these are gram-positive bacteria. Herpes simplex dendritic keratitis usually is self-limited. The primary infection is within the corneal epithelial cells. You have problems because you can get recurrence caused by a latent virus infection in the Gasserian ganglion. You tend to have recurrences, and the more recurrences you have, the more recurrences you have. In the initial stages, you see Cowdery type A intranuclear inclusions in the epithelial cells, and viral cultures may be positive. Here's the classic dendritic ulcer stained with fluorescein dye. Now, I don't have histology of the initial infection in a human. This is a experimental herpes infection in a rabbit, and we can see the viral inclusions in the epithelial cells. We do see a significant number of cases of chronic herpetic keratitis. They show things one would expect to see if the immune system is turned on. We see lymphocytes and plasma cells. We see vascularization. And interestingly, you often see giant cell reaction to Descemet's membrane. This giant cell reaction to Descemet's membrane is characteristic, but it's not pathognomonic. I've also seen this in amoebic keratitis. Amoebic keratitis is a relatively new condition related to behavior, the use or misuse of soft contact lenses. It's now understood that the ring ulcer that was described in the early descriptions of the disease actually occurs in the late stage of the condition. Cases may have relatively little inflammation, as seen on left. Here we see the amoebic cysts in the stroma. The cysts have the cytoplasmic component, which tends to pull away from the chitinous wall. I always look for the little round nucleus with the nucleolus when I'm trying to make the diagnosis. You can see the cyst quite readily with in H&E sections. There's literature in the past that talked about the use of the calcifluor white stain, a nonspecific fluorescent stain, but I'm not aware of that being readily available much anymore. This is a conjunctival scraping showing the presence of multiple acanthamoeba cysts with their chitinous walls, readily visible in the H&E stain preparation. Here's a rather florid example of acanthamoeba cysts in a recent conjunctival smear. Interstitial keratitis is a term for stromal keratitis. Luetic interstitial keratitis was the type of interstitial keratitis associated with congenital syphilis. We don't see this very much anymore. In the past, when patients would come in with this nebulous scarring of the cornea, you see this, you would make sure that to set up your slit lamp for sclerotic scatter to look for deep ghost vessels. These typically occur deep in the cornea near Descemet's membrane. Patients with chronic luetic interstitial keratitis also may have irregular guttate excrescences of Descemet's membrane in addition to the ghost vessels. Sometimes you can have rather remarkable intercameral proliferations of new Descemet's membrane seen below. A pannus is a flat scar. There are two types of pannuses. The inflammatory pannus, typically associated with trachoma, where there's an ingrowth of fibrovascular tissue beneath the epithelium with destruction of Bowman's membrane. More commonly, we see degenerative pannuses. These typically are associated with chronic corneal edema. In this, there's a layer of connective tissue interposed between the epithelium and Bowman's membrane. Peripheral corneal ulcers. The thing to remember about peripheral corneal ulcers is that they may be a corneal marker for an underlying systemic disorder. Patients may have granulomatosis with polyangiitis, it used to be called Wegener's granulomatosis, systemic lupus, or rheumatoid arthritis. The patient shown here had Wegener's granulomatosis. You have ring ulcers, Morin's ulcer, and Terrien's ulcers also occur in the periphery of the cornea. Here's an example of the overhanging margin as found in Morin's ulcer, as shown by scanning electron microscopy. This can march across the cornea, causing destruction. There's an African variant of this that can infect both eyes. So here's our typical overhanging margin. Corneal degenerations include pterygium, calcific band keratopathy, chronic actinic keratopathy, Saltzman's, nodular degeneration, keloid, staphyloma, and keratoconjunctivitis sicca. A pterygium is not a neoplasm. It's an ingrowth of conjunctiva into the peripheral cornea, possibly related to UV damage to limbal stem cells. The term pterygium is derived from the fanciful resemblance of the lesion to the wing of an insect. PTER, of course, means wing. Histopathologically, there's a lot of variation in the histology of pterygia. You tend to have, in some cases, actinic elastosis, increased vascularity, focal chronic inflammation. Actinic elastosis typically occurs in this area, and not all pterygiums have it. Calcific band keratopathy, we have a pacification of the cornea that occurs in a horizontal band. This reflects the presence of calcification. The calcification typically occurs as basophilic stippling in Bowman's layer in the anterior stroma. There's also a non-calcific variant of band keratopathy related to chronic actinic keratopathy. Chronic actinic keratopathy is a term coined by Gordon Clintworth to emphasize the probable etiological role of light in its pathogenesis. There's lots of different synonyms for this condition. Common synonyms include climatic droplet keratopathy or spheroidal degeneration, Labrador keratopathy, etc., etc., etc. The Italian term, Ciechi della Isole Dallac, refers to the presence of the disease in the Dallac Islands in the southern portion of the Red Sea. Similar disease occurs in Labrador. What the Labrador and the Red Sea Islands have in common, they have common lot of light reflected from sand in the Dallac Islands and from ice in Labrador. I like the Latin name Gernatio corneae sphereolus eloides. Eloides means olive oil. In this photograph, in the scar, we see multiple droplets of spheroidal degeneration or actinic keratopathy, which do have a remarkable similar appearance to olive oil. Histopathologically, we have these hyaline, amphiphilic spherules. The patient also has a typical band keratopathy as well. The deposits do stain with the Verhoef Van Giesen elastic stain, but the staining is not abolished by elastase digestion. The patient with the chronic actinic elastosis actually is the coal miner with the accidental tattooing that we saw previously. Histopathology of this penetrating keratoplasty specimen shows black particles of coal in the corneal stroma. No inflammation is noted. Saltzman's nodular degeneration. We see a fair number of cases of this recently. Essentially is subepithelial fibrosis. Here's a case of rather extensive subepithelial fibrosis that we saw a few years ago. This is an example of a corneal staphyloma. It's a child from Haiti. The eye was sent to our laboratory because it was thought to contain a retinoblastoma, which it didn't. Here's the sectioned eye. We can see the ectatic cornea. Well, the cornea is ectatic, but it also has undergone secondary keloid formation. Now, the ectatic cornea is lined internally by uveal tissue, by iris. So this is a staphyloma. A staphyloma is defined as an ectasia lined by uveal tissue. Again, we have two grape words here. Staphylo means a bunch of grapes, and uva means grapes. So staphyloma, ectasia lined by uveal tissue. This is a patient that was seen in the Wills emergency room a few years ago. She presented with a spontaneous perforation in her cornea. Note her fellow eye looks totally dry with conjunctival folds. She was a chronic alcoholic with undetectable levels of vitamin A, and this is an example of keratomalacia secondary to avitaminosis A. There's a higher magnification of the perforation. It's actually been covered by corneal epithelium, as we see here. The perforation, which is sharply margined, is filled with iris stroma. The retina is detached, and most of the lens has also been ruptured and lost. The cornea can be involved in various lipid disorders. Of course, arcus senilis is deposition of extracellular lipid, clinically significant in men less than age 40. Lecithin cholesterol acetyltransferase deficiency, or Norham's disease. We have fisheye disease, Tangier disease, and Schneider's corneal dystrophy. Tangier disease is somewhat of a medical curiosity. Tangier disease is named after Tangier Island down in the Chesapeake Bay in Virginia. There's people that have lived there for hundreds of years catching crabs and oysters, and there's a lot of inbreeding, and this high-density lipoprotein deficiency developed in that island. They may have corneal clouding, and they have this very characteristic feature of orange-striped tonsils. Here's an example of diffuse corneal opacification in LCAT deficiency. Keratoconus is a corneal degeneration. See a case here with resorbing hydrops. It's a bilateral condition with an onset around puberty. It doesn't have a definite heredity to it. It's Sometimes more common in some kindreds, but there's definitely the inheritance is unclear. Again, there's a central stromal ectasia. The corneal stroma has an abnormal consistency. They're characteristic dehiscences in Bowman's layer. There's a ring of iron in the epithelium around the cone, and ruptures in Descemet's membrane can occur spontaneously, giving rise to acute edema called acute hydrops. You have Volt's lines in the cornea and Munson sign. There's some systemic associations. Leber's congenital amaurosis, that's really academic since they're already blind from that. Eye rubbing. Eye rubbing does play a role. There's some cases where patients have developed keratoconus on one eye, which they constantly rubbed, and had a normal eye on the other side. The cause is uncertain, probably an abnormality in the extracellular matrix. Here's a histology photo showing the ectatic cornea, centrally ectatic cornea with an abnormal wavy conformation. You can have compensatory hyperplasia of the epithelium, as we see below, and multiple breaks or dehiscences in Bowman's layer. Here's one of these dehiscences shown under higher magnification. They frequently have this sort of wavy conformation. This is a photo of acute hydrops. The acute phase is shown at left, and same patient shown at right after partial resorption. The histopathology below shows that the corneal endothelium has migrated, filling the gap, and is now laying down a new thin layer of Descemet's membrane. So, acute hydrops. This is a Fleischer ring, a ring of iron in the corneal epithelium surrounding the cone. Iron lines are better or best viewed with the cobalt blue filter and the slit lamp. Fleischer ring was named after the same Fleischer as Kaiser Fleischer. Again, this is iron in the epithelium. Remember, iron is deposited in epithelium and norepithelial structures. Other eponymic corneal iron lines include Hudson-Stolly line at the meniscus between the tear meniscus between the lower lid, lower third of the cornea, Stalker line in front of a pterygium, and a Furry line in front of the filtering bed. Corneal rings. A arcus senilis that extends 360 degrees is called an annulus senilis. Of course, the classic Kaiser-Fleischer ring is associated with Wilson's patolenticular degeneration. This is copper in Descemet's membrane. Patients may also have copper in the lens capsule, so-called in the sunflower cataract. There are some other causes of copper deposition in the cornea. Some cases of protein dyscrasias like myeloma, the abnormal proteins may act as a copper transport protein. It's also been associated with some forms of liver disease. Corneal dystrophies. Corneal dystrophies are rare, but they're interesting conditions, and questions frequently are asked about them because it's easy to ask questions about them. Classically, the term dystrophy denoted an inherited, relatively symmetric or bilateral disease which didn't have vascularization or inflammation in its early stages. Again, the term is also applied to heritable diseases of the macula. We now know that these are inherited defects in structural proteins or enzymes. Typically, they're not present at birth. They become clinically evident later. And the pathology seems to be localized to an ocular tissue. We now know that at least one of the corneal dystrophies, macular dystrophy, actually is a systemic disease, but the other systemic effects are absent, inappropriate, or innocuous, or inapparent or innocuous. IC3D classification is a great resource dealing with modern classification of the corneal dystrophies. This is available on the internet. It has clinical photographs and pathology photographs. You should go through the Cornea Society's website to get access to this. Corneal dystrophies classically are classified topographically. We talked about epithelial dystrophies and dystrophies of Bowman's membrane, stromal dystrophies, and endothelial dystrophies. The anterior corneal dystrophies include Meesman's, Stocker-Holt, map dot and fingerprint, which actually probably is not a dystrophy in most instances, and Lish dystrophy, band-shaped and whorled microcystic dystrophy. The new IC3D classification includes these categories: epithelial and subepithelial dystrophies, 2 epithelial stromal dystrophies caused by mutations in TGFBI gene, stromal dystrophies, and endothelial dystrophies. Again, the epithelial and subepithelial dystrophies include Meesman's, Lish, and gelatinous dop-like dystrophy, and some other rarer dystrophies. This new classification, epithelial stromal dystrophies caused by mutations in TGFBI, includes 5 or 6 dystrophies caused by different allelic mutations in the same gene, the TGFBI gene. These include Reese-Buchler's and Thiel-Behnke's dystrophy, which previously were classified as Bowman membrane dystrophies, lattice corneal dystrophy type 1, granular corneal dystrophy type 1, and granular dystrophy type 2, which used to be called combined granular lattice or Avellino dystrophy. In the IC3D classification, second edition, the stromal dystrophies include macular, Schneider corneal dystrophy, congenital stromal, Fleck corneal dystrophy, and deep amorphous corneal dystrophies. The classic granular and lattice dystrophies of the stroma are now included with the TGFBI dystrophies. Of course, the endothelial dystrophies, Fuchs dystrophy is by far the most common corneal dystrophy. We also have CHED, or congenital hereditary endothelial dystrophy, and talk about posterior polymorphous and X-linked endothelial dystrophies. I've never seen a case of that, but has a moon crater-like formations on Descemet's membrane. Let's talk about the epithelial and subepithelial dystrophies. Meesman's dystrophy is somewhat of a medical curiosity. It essentially involves the epithelium. The epithelium tends to be thickened. There's thickening of the epithelial basement membrane, and there's vacuoles in the epithelium that tend to get filled up with fluorescein dye. It may not interfere with vision very much. Again, it's autosomal dominant. It can have recurrent erosions, and we have these small intraepithelial vacuoles. Now, there are heritable defects in corneal epithelial specific cytokeratins, namely K3 and K12. This leads to a so-called epithelial fragility syndrome. There's also abnormal cytoskeletal material in the epithelial cells, and this has been called peculiar substance. You need electron microscopy to see this. Map dot and fingerprint, or anterior basement membrane dystrophy. It's now appreciated that the great majority of these cases aren't heritable. You can see changes identical to map dot and fingerprint. A lot of cases of chronic corneal edema and bullous keratopathy. The map form corresponded to Kogun's microcystic degeneration. The putty-like material in the dots are actually composed of devitalized epithelial cells trapped between 2 layers of reduplicated epithelium. Fingerprint dystrophy has intraepithelial basement membrane. Probably the worst dystrophy to have is gelatinous drop-like dystrophy. This is actually recurrence in the graft after a year. Gelatinous drop-like dystrophy is also termed familial subepithelial amyloidosis. It was originally described in Japan back in 1914. The gene is the TACSTD2 gene, tumor-associated calcium signal transducer 2 gene, which encodes a membrane permeability protein. It's interesting, the amyloid, the massive deposits of amyloid in gelatinous drop-like contain lactoferrin, but the dystrophy is not caused by mutations in the lactoferrin gene. Lactoferrin passes through the permeable corneal epithelium and accumulates as amyloid. Here's a histopathology showing a massive subepithelial deposit of amyloid in a case. Of course, the amyloid stains positively with the Congo red stain, and exhibits characteristic apple green birefringence to polarized light. This is an example of Reese-Buchler's corneal dystrophy, one of the TGFBI dystrophies that initially was classified as a dystrophy of Bowman's membrane. Corneal dystrophy Bowman's 1, Reese-Buchler's, and corneal dystrophy Bowman's membrane 2, or Thiel-Behnke. Both of these have TGFBI mutations. They both have sawtoothing of the epithelium and a laminated pannus with alternating deposits of TGFBI protein and collagen. Here's histology of Reese-Buchler's. We see the characteristic sawtoothing, thick and thin appearance of the corneal epithelium. Beneath the epithelium is this laminated pannus composed of alternating layers of abnormal TGFBI protein, which are intensely eosinophilic, separated by collagen. There's frequently destruction of Bowman's membrane. In this case, does have a few granules down in the deeper stroma. Here under higher magnification, we're looking at the laminated pannus. We can see that the deposits stain intensely red with Masson trichrome, which is also the stain that we use for granular corneal dystrophy. Reese-Buchler's essentially is a superficial form of granular dystrophy. You can do electron microscopy on these Bowman's membrane dystrophies. Reese-Buchler's is characterized by the presence of osmophilic crystalloids of TGFBI protein. Reese-Buchler's, in contrast, has structures called curly filaments. Sometimes with good light microscopy, you can distinguish them. You can see the crystalloids in Reese-Buchler's. The classic stromal dystrophies in the past were granular, lattice, and macular. Here's the old chart: granular, hyaline, lattice, amyloid, macular, mucopolysaccharide. Now, hyaline is a nonspecific descriptive term meaning glassy. We now know that the hyaline granules are actually composed of TGFBI protein, and the amyloid in lattice is composed of TGFBI protein as well. You can see the classic stains of choice: colloidal iron or Alcyon blue for macular, Masson trichrome for granular, and Congo red with polarization for lattice. A bunch of mnemonics for corneal stromal dystrophies shown here. Again, TGFBI stands for transforming growth factor induced gene. It used to be called the big H3 gene, which is actually easier to remember. We can see that the dystrophies that are associated with mutations. Polymorphous amyloid dystrophy is one that was described by Gordon Clintworth. Again, the gene is located on the long arm of chromosome 5q31. The corneal epithelium is rich in TGFBI protein and occasionally is called keratoepithelin. Different patterns of precipitation or aggregation of the several mutant forms of TGFBI protein presumably are responsible for the various clinical manifestations. One of the better corneal dystrophies to have is granular corneal dystrophy. Granular is granular clinically, by light microscopy, and by electron microscopy. The deposits may have a granular or annular appearance. Here's another example with the larger deposits. One of the reasons these patients tend to do well is due to the fact that there is actually clear functional cornea between the deposits. Histopathologically, the deposits are more intensely eosinophilic than the surrounding stroma, and they have an appearance which has been likened to rock candy. They have crunchy margins. The stain of choice is the Masson trichrome stain. The deposits stain red. That's called positive acid fuchsinophilia. Interestingly, they also stain with Luxol fast blue, a stain for myelin, and they are negative with PAS. In lattice dystrophy type 1, the TGFBI protein deposits out as linear deposits of amyloid. Of course, the stain of choice is the Congo red stain. Here's a H&E section. Deposits here are sort of amphiphilic. They're sort of a combination of basophilic and eosinophilic. Again, in contrast to the deposits in granular dystrophy, these have sort of a smudgy appearance. They have smudgy margins. And here's a positive Congo red stain for amyloid. And of course, we put our Polaroid filters on and we can see the apple green birefringence. And if you rotate your filters, the green areas will turn orange. And this is called dichroism, birefringence and dichroism. This polymorphic corneal amyloid dystrophy, described by Gordon Clintworth. The amyloid in this dystrophy has been likened to ice chips. Here are some of the mutations found in several of the TGFBI corneal dystrophies. Note that the dystrophies with granules, granular and Reese-Bucklers, have a mutation at position 555, whereas 124 is associated with amyloid deposition. Baratoya syndrome is a systemic disease. It once was called lattice corneal dystrophy type 2. This is caused by mutations in gelselin, the gene for gelselin, GSN gene, which is involved in actin metabolism. This is a photograph showing very inconspicuous lattice-like lines in a case that was posted in the IC3D website. This is a systemic disease. The patients have cranial nerve palsies. They can have dry, lax, itchy skin, mask-like hound dog facies with protruding lips, pendulous ears, and they can have systemic amyloid as well. This is a case of macular corneal dystrophy. The term macular refers to the white spots or macules. Now, a macular dystrophy tends to become symptomatic relatively early, and that's because there is, in addition to the macules, diffuse haze of the corneal stroma, which extends from limbus to limbus, giving rise to early visual loss. Here's another example with macules and diffuse haze. Now, macular dystrophy is caused by defect in an enzyme. Enzyme defects typically are recessive. This is a autosomal recessive process. The enzyme is the CHST6 sulfotransferase gene on 16q22. This typically adds sulfate, called sulfonation, of a protoglycan called keratan sulfate. The non-sulfated keratan sulfate accumulates in the keratocytes, endothelial cells, and large clefts in the stroma. This also leads to improper hydration of the stroma, causing the diffuse haze, and also causing corneal thinning. The cornea is definitely thinner in cases of macular dystrophy. This also, in some instances, appears to be an innocuous systemic disease. There's different subcategories of macular dystrophy. Patients with type 1 macular lack keratan sulfate in their serum and cartilage, but doesn't seem to do anything bad in the serum and cartilage. Essentially, it causes a pacification of the cornea. The stain of choice is the colloidal iron stain or the Alcyon blue stains for mucopolysaccharide. Here are two photomicrographs stained with colloidal iron. At the top, we see one of the larger extracellular deposits of the keratan sulfate. Below, we see the intrakeratocyte deposits and deposits within the endothelial cells. Also note the guttate excrescence of Descemet's membrane. Guttate excrescences can occur in macular dystrophy. Again, we've seen them in interstitial keratitis, and we will see them most commonly in Fuchs endothelial dystrophy. Here's an example of Hurler syndrome. Some instances, the cornea is massively thickened by mucopolysaccharide deposition. We never used to get specimens from these in the past because the patients typically died like age 4 or 5 from aspiration pneumonia. But recently we did have specimens from this patient who was, his picture's actually on the internet. He had a bone marrow transplantation, which helped to ameliorate some of his systemic symptoms. Of course, the bone marrow transplant can't get into his cornea, so it doesn't affect corneal clouding. Here's this clouded cornea. We can see with the slit lamp, the cornea does not look that thickened. Here's the histology showing the blue deposits in the epithelium and Bowman's membrane and the keratocytes. It's the colloidal iron stain, and again, more deposits in the keratocytes and the endothelial cells. Schneider's, the Europeans say it's Schneider's, not Schneider's. Used to be called Schneider's crystalline dystrophy. It's now called Schneider's corneal dystrophy because only 50% of the patients actually have the cholesterol clefts. They typically have a prominent arcus. This is a dominant condition. The gene is UBIAD1 gene. Other rarer stromal dystrophies include Franz-Von-Niten's Fleck dystrophy or dystrophy Moucheté. The Moucheté means flies. The deposits tend to look like fly specks. You have CHED, congenital hereditary stromal dystrophy, and these other ones that I'm not particularly familiar with. Franz-Von-Niten's is almost a medical curiosity. The deposits actually don't interfere with vision very much. Endothelial dystrophies, Fuchs dystrophy is the most common dystrophy by far. We typically see several cases a week in the laboratory. They're now treated with Decimase stripping endothelial keratectomy or DSEC or DMEC. Posterior polymorphous dystrophy we'll talk about, and then we have CHED. Here's an example of corneal edema and bullous keratopathy. Different causes for corneal edema and bullous keratopathy. We look at Decimase membrane to make the diagnosis. In this photo, Decimase looks normal, and we don't see any endothelium, so this would be consistent with pseudophakic bullous keratopathy or, say, aphakic bullous keratopathy. Here's another example of bullous keratopathy. In this instance, Decimase membrane is irregularly thickened with guttate excrescences, so this is what we see in Fuchs dystrophy. Scanning micrograph showing the anvil or mushroom-shaped deposits, thickening Decimase membrane. In this area, there's actually loss of the endothelium. The inheritance of Fuchs dystrophy is complex. The family history is often negative. Our cases with rare mutations in collagen 8A2. Now, people talk about guttata. Well, guttata is actually an adjective. The term cornea guttata means drop-like cornea. So it's gutta is a symbol, and gutti is the plural. Guttate excrescences. This is a specimen from a patient with Fuchs dystrophy. The specimen is a DSEC specimen. We're looking down on stripped Decimase membrane. The circular structures are the gutti. We see there's a significant amount of residual endothelium here, and a lot of the endothelial cells contain granules of iris pigment epithelial melanin. Okay, up above we see pseudophakic bullous keratopathy with severe corneal stromal edema. Severe edema has this cotton candy-like appearance. The edema in the Fuchs case below is not as intense. Pseudophakic bullous keratopathy, the Decimase membrane is normal in caliber. We don't see guttate excrescences, and we don't see much in the way of endothelium that's left. In contrast, we see the guttate excrescences in Fuchs dystrophy and some residual endothelial cells, some of which contain granules of melanin. Posterior polymorphous dystrophy, they're granular and vesicular deposits at the plane of Decimase membrane. Rarely you may see these gutter-like formations as well. Posterior polymorphous dystrophy, the scanning micrograph shows the highly irregular endothelial mosaic with microvillous processes on the surface of the cells. The thing to remember about posterior polymorphous is the endothelium has epithelial characteristics. This includes proliferation as multiple layers, as we see below in the histopathology. Cells have tonofilaments, they have the surface microvilli, and the endothelial cells express epithelial antigens if you do immunohistochemical stains. Corneal and systemic disease, you can have deposition of abnormal immunoglobulins in cases of multiple myeloma or monoclonal glomerulopathy of unknown significance. This can occur as crystals in the epithelium or amorphous deposits in the deeper stroma. Fabry's disease have cornea verticillata. We talked about Wilson's and ochronosis and the lipid disorders. This is an example of corneal crystals in a patient with multiple myeloma. Other causes of crystals include cystinosis, Bieti's dystrophy, which also has crystals in the retina. I've never seen a case of that. Cholesterol and Schneider's dystrophy. Plant sap acid injury, I'll show you an example of that. Dieffenbachia keratopathy. Here's another thing that you can see in a multiple myeloma. Patients with multiple myeloma typically have cysts of the pars plana and occasionally the pars placata. The cysts are classically stated to be white due to the precipitation of the myeloma protein. Well, this is a fixation artifact. On the left, we see an unfixed specimen. A half an hour after immersion in formaldehyde, the cysts have turned white. So white cysts are a fixation artifact. Here's an example of cystinosis. The cystine crystals are soluble in water. If you want to preserve them, you have to fix in absolute alcohol. Here's an example of Dieffenbachia, phytocrystalline keratopathy. This woman was tending her house plant about 6 hours previously and got a drop of sap in her eye. She had itchy burnies and was found to have multiple crystals in her epithelium in addition to superficial punctate keratopathy. Note that some of the crystals appear to be down at the level of Descemet's membrane. This is the house plant. This is a very, very common ornamental house plant. I think every Walmart in the country sells this. The sap of the plant is filled with needle-like calcium oxate crystals called raphides, and the plant also has these interesting crystal-forming organelles. So I actually saw 3 cases of Dieffenbachia keratopathy in a 6-month period many years ago. So that's cornea. The lens. The lens is the only transparent cellular structure in the eye. Its major function is change in focus or accommodation. Here are some congenital or pediatric conditions of the lens. We can see an anterior pyramidal cataract, a pediatric version of anterior subcapsular cataract. See a lamellar form of cataract. This is lens coloboma. Lens coloboma is a secondary phenomenon caused by loss of zonular fibers in a corresponding coloboma of the ciliary body. If you see what looks like a lens coloboma in a patient without a ciliary body coloboma, think of the possibility of a tumor of the ciliary body like a medulloepithelioma. The oil droplet-like appearance we see here is a case of posterior lendiconus. Anterior lendiconus is seen in Alport syndrome of hereditary hemorrhagic nephritis. This is caused by mutations in the gene for type 4 or basement membrane collagen. Here we see the protruding lendiconus. Here's electron microscopy of a case of Alport syndrome by Dr. Barbara Streeton. We can see that the lens capsule is highly abnormal. It's thin and has these interesting dehiscences. Posterior lendiconus is unassociated with systemic disease. In the parallel pipette slit lamp photo on the right, we see the posterior bulging of the cortex in the area of lendiconus, and there's some associated cortical change as well. Congenital cataracts, there's a rule of 3. 1/3 are hereditary, 1/3 are idiopathic, and 1/3 are associated with systemic disease. These 2 congenital cataracts show very nicely. The Y sutures in the lens that delimit the embryonic nucleus of the lens. The term zonular cataract refers to a zone of opacification in the lens, not the zonular fibers. Cataract at the left is a dust-like opacification of the embryonic nucleus, so-called cataract of centralis pulverulenta. On the right is a lamellar cataract. So we have zones of opacification. A classic example of zonular cataract occurred in patients who had attacks of neonatal tetany. During the attack, the intrauterine insult opacified a zone of developing lens fibers, and these were subsequently buried by the formation of new clear lens cortex. Cataracts, the end stage, are the final common pathway of lens pathology. Lots of different things can cause cataracts, of course, the most common being aging. Relatively low doses of ionizing radiation can cause cataract. Cataracts occur in systemic diseases. They tend to patients with diabetes tend to develop cataracts 10 years earlier. Certain toxins and drugs can cause cataract. Inborn errors of metabolism. Trauma, appropriate type of trauma can give rise a cataract in 24-48 hours. There are 4 basic types of cataract that the pathologist can identify under the microscope in the lab. They include anterior subcapsular cataracts, posterior subcapsular cataracts, cortical cataract, and nuclear sclerosis, and we'll go through these. Again, the lens has a relative limited vocabulary of histopathologic expression. We see anterior subcapsular cataracts all the time in the laboratory, but you don't see them clinically that often because they tend to be hidden by posterior synechias or pupillary membranes that sort of cause their formation. Here's a nice example of a anterior plaque of collagen on the surface of a sclerotic nucleus. Another example, at top left, we see a patient with neovascular glaucoma and prominent ectropia on the white plaque on the surface of the lens is an anterior subcapsular cataract. We can see the cataract beneath an area of posterior synechia formation. We can see our PAS stains. They show the PAS positive anterior lens capsule, and they also show PAS positive capsules surrounding the epithelial cells in the fibrous plaque. Fibroblasts don't have basement membrane capsules, so this tells you that these are lens epithelial cells. Higher magnification showing the PAS positive capsules surrounding the lens cells that form the fibrous plaque. Masson trichrome stains blue. That tells you that this is collagen. The collagen plaque tends to contract, and this causes multiple folds in the anterior lens capsule. And another example, anterior subcapsular fibrous plaque in an area of synechial closure. Posterior subcapsular cataract. Normally, the lens epithelium, the monolayer of anterior lens epithelial cells terminates at the equatorial lens bow. Under certain circumstances, however, noxious influences can cause the lens epithelium to migrate posterior to the equatorial lens bow to the posterior pole of the lens, where the cells attempt to make new lens fibers, but they do cause these aberrant, abnormal lens fibers called bladder cells or Wadel cells. And these can accumulate, causing a posterior subcapsular cataract. Similar things can happen after extracapsular surgery. It's an example of capsular fibrosis. We see the lens epithelial cells surrounded by the basement membrane capsules, plaque of collagen on the anterior lens capsule in the vicinity of the capsula rhexis. This is an example of capsular phimosis with the corresponding histopathology below. Elschnick's pearls are analogous to bladder cells or Wadel cells that form after extracapsular surgery. The clinical photo looks like an aggregate of fish eggs on the surface of the lens capsule, the Elschnick's pearls. This patient is an old photo. The cataract was treated by cutting it or slicing it with a needle. This would lead to spontaneous resorption of the lens, and frequently you would develop these bladder cell-like formations. Below, we can compare the thickness of the anterior capsule with the posterior lens capsule. The posterior lens capsule is actually less than the diameter of a red blood cell. So, cortical cataract, soft cataract, we have degeneration of the cortex. This initially occurs as clefts or vacuoles in the substance of the lens. We see more Gagnian globules. These are spherules of degenerated lens protein, or perhaps lens cytoplasm that oozes out of fractured lens fibers. More examples of Morgagnian globules, named after Morgagni. Total liquefaction, total degeneration of the cortex is seen in Morgagnian cataract. The lens nucleus typically is sclerotic. It resists liquefaction and tends to sink inferiorly in the milky bag of liquefied cortical material. The photomicrograph is actually a very, very old photo from the Armed Forces Institute of Pathology. The molecular weight of the cortical material gets so small that it has a very profound osmotic effect. It sucks in aqueous and makes the lens swell. And this can give rise to an intumescent cataract that can cause phacomorphic glaucoma. Under higher magnification, we look at the sclerotic lens nucleus here, and we can see multiple little lighter round areas. These correspond to calcium oxalate crystals, which can be associated with severe nuclear sclerosis. Here's an example of florid calcium oxalate crystals. One of our residents was doing cataract over in Camden and had some problems with a sclerotic nucleus. This was removed and submitted to pathology, and it was just absolutely loaded with oxalate crystals. Now, the lens is derived from surface ectoderm, just like the skin. In the skin, the skin grows constantly throughout life, and we constantly desquamate our older cells. We can't desquamate our older lens cells. Rather, we sequester them to the center of the lens. So both derive from surface ectoderm. So nuclear sclerosis is inevitable in the growth and development of the lens. The older inwardly sequestered lens fibers degenerate. We see increased eosinophilia of the nucleus. We see loss of the normal artifactitious clefts. There's accumulation of yellow-brown urochrome pigment, which can lead to blue-yellow color defects. And the index of refraction of the sclerotic nucleus also increases. That bends light more and leading to lenticular myopia, which was termed grandma's second sight. You can also see brown cataracts and black cataracts and calcium oxalate crystal. Histopathology is not very exciting. We see increased eosinophilia and loss of the artifactitious clefts, which normally occur when you section lens. These photographs show a sclerotic nucleus, cataract that developed after a glaucoma surgery. We see the oil droplet appearance related to increased index of refraction. Again, these can give rise to lenticular myopia. Now, the parallelepiped shows the urochrome pigment in the nucleus. Again, can be concerned of blue color defects. This is a painting by a patient of a English ophthalmologist. He asked the patient to do the painting prior to cataract surgery. Due to the nuclear sclerosis, we see these ochres and earth tones. Post-operatively, there's a much cooler palette, much more blue is apparent post-operatively. patients may complain of blue vision after nuclear sclerotic cataracts are removed. And one of the classic examples of that was the French Impressionist artist Monet. Here's I don't know how many variations of this painting by Monet I've seen in different museums. It's the Japanese bridge over the water lilies at his garden in Giverny. He painted this, his cataracts got bad. Here's the same painting after his cataracts got bad. He had successful cataract surgery, but he was so upset with his blue vision that he had the special pair of cataract glasses made with yellow lenses. Complicated cataracts are cataracts associated or secondary to ocular diseases. Classic example is Fuchs heterochromic cyclitis. Cataracts can also develop in patients with chronic uveitis, like sarcoid or juvenile rheumatoid arthritis, paucicellular RF seronegative ANA positive. Cataracts are associated with retinitis pigmentosa. That's an interesting association. Somehow the retina is talking to the lens. You also have to remember that ciliary body tumors can give rise to cataracts. It's very embarrassing to diagnose a melanoma during cataract surgery. Glaucom flecken are tiny lens opacities that occur in cases of chronic closed-angle glaucoma. Fuchs heterochromic cyclitis, some question whether this is maybe due to prior rubella infection. The cataract develops in an eye that develops hypochromic heterochromia. There's frequently a low-grade uveitis with stellate or fusiform chromatic precipitates, which frequently does not require treatment. The patients tend to do very well at surgery, but may develop a innocuous fusiform hyphema during surgery. Sugar cataracts are osmotic cataracts caused by the accumulation of sugar alcohols within lens cells. The sugar alcohols are made by the aldose reductase pathway when the normal glycolytic pathway is swamped by excess substrate. The sugar alcohol in diabetes is sorbitol. The sugar alcohol in galactosemia is galactitol or dulcitol. Here's an interesting case. This was a young type 1 diabetic whose initial manifestations of diabetes was this osmotic cataract, sort of this lacy appearance. This actually went away when the patient was started on insulin. Of course, diabetics can also have changes in their refraction. They tend to become myopic when their sugar is elevated. Here's an example of a galactosemic cataract. The galactosemic cataract may be the initial manifestation of galactosemia. Ectopia lentis refers to spontaneous dislocation of the lens. Ectopia lentis typically is due to primary and secondary defects in an elastic microfibrillar protein called fibrillin. Common causes include Marfan syndrome, probably the most common cause of ectopia lentis. The lens typically dislocates up and out. These patients do have primary defects in fibrillin. This problem with elastic tissue is also responsible for the other manifestations of the condition, include the tau habitus, the spidery digits, dissecting aneurysms, and cardiac disease. In homocystinuria, this is a recessive cisethionine synthase deficiency. This is a defect in sulfur-containing amino acids, and this interferes with secondarily with the formation of disulfide bonds in fibrillin. Classically, the lens dislocates down and inferiorly, and down and nasally, or into the anterior chamber. Another interesting thing about homocystinuria is that the patients have abnormal platelets and are subject to thromboembolic complications. Warr-Marcassani syndrome. These patients have short stature, brachydactyly, deafness, inflexible joints. They then have a very small round lens, microspherophakia. This gives rise to high degrees of lenticular myopia and childhood, and then the lens dislocates anteriorly, causing secondary pupillary block glaucoma. And there's a variety of other deficiency, sulfate oxidase deficiency, is rare and also involves sulfur-containing amino acids, isolated ectopia lentis, fibrillin mutations that have no other systemic abnormalities. Here's an example of Marfan's with a superior dislocation in the dragged zonular fibers. There tends to be more global abnormalities with the zonule in homocystinuria. Here's an example of dislocation into the anterior chamber. Patients with homocystinuria have abnormal platelets. You have to be concerned about the development of thromboembolic complications under general anesthesia. A rare case of ectopia lentis occurs in Trabulsi syndrome. This also includes facial dysmorphism, including a big hooked nose that this patient has, and a very interesting feature, which I don't know occurs in anything else, and that is the development of spontaneous filtering blebs. This is a chart from Dr. Trabulsi showing some other rare associations with ectopia lentis, like Knobloch syndrome and Cohen syndrome, what have you. Pseudoexfoliation of the lens capsule. Pseudoexfoliation, lens capsule, the term was coined by Dvorak Theobald to distinguish this common condition from true exfoliation or capsular delamination, which is rather uncommon. In pseudoexfoliation, there's an abnormal mucoprotein that's made by the epithelium, the lens, the iris, and the ciliary body. There's typically 3 concentric zones of material on the anterior lens. About 50% of the patients develop secondary open-angle glaucoma that's been termed glaucoma capsulare. In some areas of the world, this is a very, very important cause of glaucoma. Patients also have abnormalities of the iris pigment epithelium. They have a sawtooth pattern, and this leads to dispersion of pigment. The pupil also dilates poorly. Now, the patients also have a problem with developing spontaneous dislocation of the lens or lens capsule. There's some electron microscopic evidence that pseudoexfoliation actually is the ocular manifestation of a benign systemic disease of elastic tissue, because exfoliation material has been found in the lung and the liver. Here's a classic photo of pseudoexfoliation on the anterior lens from Dr. Marignano's collection. We have this typical target-like appearance. The bullseye of the target corresponds to the diameter of the undilated pupil. Then there's a more peripheral area where the material has been wiped clean by pupillary mechanics, and out in the periphery there's this radial area with areas where the material is peeling off the surface of the lens, and this sort of looks like exfoliation. The iris pigment epithelial abnormalities are seen at top left. There's this coarse sawtoothing of the iris pigment epithelium. This leads to dispersion of pigment. The material on the anterior lens capsule is seen at bottom left. The material is made by the lens epithelial cells and extruded through the capsule, forming these so-called Bisacca deposits, which have been likened to iron filings on a magnet. We also see massive amounts of exfoliation material on this ciliary processes here. The presence of the material on the ciliary body presumably interferes with the zonular attachments, leading to this propensity for spontaneous dislocation. This is a sort of a medical curiosity. This is Polychromasia capsularia. There's a family in the Ohio area that actually has iridescent lens capsules. This is one of the few examples, I think, of true iridescence of human tissue. Here's a segment of the lens capsule after surgery, and this montage shows a fragment of lens capsule from an affected patient. We can see that the color of the lens capsule changes when the incidence of illumination changes, which is consistent with the definition of iridescence. Electron microscopy shows abnormalities in the capsule that are probably responsible for this. This is a traumatic cataract, a submarine ring cataract. In submarine ring, you have loss of the nucleus with persistence of cortical material in the recesses of the capsular bag. This was due to non-surgical trauma. We see submarine ring-like appearances not infrequently in eyes after extracapsular surgery and IOL implantation. We see this in eyes that are removed for tumors that have had prior lens surgery. Another rare traumatic cataract. This is an electrical cataract. You can have two types of electrical cataracts. Cataracts caused by lightning and cataracts caused by high tension wires. The high tension wire supposedly is more likely to pacify the anterior capsule, whereas the lightning strikes go down the neuraxis if you're hitting the top of your head, and pacify the posterior capsule, which I've always thought is one of the more ridiculous differential points in medicine. Here's a siderotic cataract with a patient with iron foreign body. We see the rusty discoloration of aggregates of lens cells. This is the cataract that occurs in myotonic dystrophy. Cataract is common. They have little polychromatic crystals in the anterior and posterior subcapsular cortex. Of course, you have myotonia, frontal baldness, testicular atrophy. Of course, remember the lens is derived from surface ectoderm, so there is an association between certain skin diseases and cataract. This is so-called syndermatotic cataracts, reflecting this common derivation of both structures from surface ectoderm. I think the most important syndermatotic cataract is the atopic cataract associated with atopic dermatitis. They used to say that these patients did poorly at surgery and should be referred or deferred. And then we have some of the rarer symptoms. The young man in the photograph has a rare condition called acrodermatitis enteropathica with an obvious cataract.